Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case about a 48-year-old male who came to our ER with complaints of high-grade fever with chills and rigor associated with lower abdominal pain and loose stools for the past 2 days.
Okay.
Shall we begin, sir? Sir, on initial assessment, the patient was conscious, oriented, and was talking. Coming to the airway was patent. There was no pooling of secretions. In the breathing part, he was having mild tachypnea. Respiratory rate was 20 to 25 per minute with saturation of 100% maintained in room air. At that point itself, we put a simple nasal cannula for O2 support, and along further moving on with the discussion.
O2 support means how much oxygen is started in
2 liter via nasal cannula.
What is the saturation?
Initial saturation was 100% maintained in room air, but as he was having tachypnea. We put a nasal cannula.
What are the reasons for tachypnea in emergency?
LRT, lower respiratory tract infection. Patient panic attack. Anxiety, panic attack. Then patient.
What is the commonest cause for tachypnea in a emergency room like this? Not in a routine setup. Whatever you told, that is commonest thing in a general setup, like respiratory infection, panic attacks. What is it called?
Pulmonary edema.
Pulmonary edema. Okay, then cardiac failure, pulmonary edema.
COPD.
It's all respiratory failure.
Infections. Then a sepsis patient.
What is the reason?
Yeah.
Acidosis.
Metabolic acidosis.
Acidosis is one of the most common condition you are seeing here, where the patient is having tachypnea. To correct the acid-base disorder. Okay, so there is, even if you start oxygen, it will not improve. Okay, but other conditions like you have a patient with COPD, asthma, where the tachypnea can be controlled with simple oxygen therapy itself. But sepsis as such, the tachypnea will not be controlled with oxygen. Okay.
Coming to the circulation, but his BP at that point was 60.
What happened to the ABG in a tachypnea like that? In sepsis, what happens to ABG?
ABG patient might having a...
Because of tachypnea, what happens to the
CO2 washout occurs.
CO2 washout occurs. So again, if you give oxygen, what will happen? So patient can have hyperoxemia. That itself can sometimes produce damage to your internal organs. Okay, so without hypoxemia or hypercarbemia, it will be like dangerous to give oxygen in a patient with simple tachypnea. But like you told, the reason is due to respiratory disorder, then it is correct. But in sepsis and all, it may not be helpful. Sometimes it will be harmful also.
Further on, moving on, circulation on BP was 60 or 40 mmHg, sir.
60 by 40.
And pulse rate of 100 per minute. We at that point also we secured 2 large bore IV cannulas. And
so you think that this 100 beats per minute pulse rate is accurate for your BP?
Sir, because of BP, patient might have temperature.
BP is low, but heart rate is only
100.
What is the reason for that?
Yeah.
Relative bradycardia.
Tachycardia. Hypertension causing the...
What are the conditions which can produce bradycardia when you are expecting tachycardia? What are the conditions which can produce bradycardia in this type of situations? Normally when you have a shock, there has to be tachycardia. Here you are not seeing. What are the reasons for that?
So, malaria, then...
maybe the patient is on beta block.
Most common condition is patient is on a drug which can reduce the heart rate. That is the most common condition. Second thing is myocarditis. Myocarditis sometimes can produce tachycardia. Sometimes it can produce bradycardia also. Okay. So these are the two important things. Sometimes the patient will be on beta blockers or calcium channel blockers which reduces heart rate, digoxin. That may be the reason. Sometimes it may be due to the carditis. Carditis can sometimes produce tachycardia, sometimes can produce bradycardia. So we have to be very careful. If the patient is having bradycardia, there is some other problem will be there.
And And sir, we secured 2 large bore IV cannula, and initially as patient history itself having loose stools history, we started with IV fluid bolus was given, sir, initially. And further assessment, we followed with the further assessment. Disability wise, GCS was full score and pupil were bilaterally reacting. And exposure wise, temperature was 100 Fahrenheit, and we given him an injection paracetamol at that point of time, sir. GRBS was 255 milligram per deciliter. Coming to the adjuncts of the primary survey, we took an VBG which was showing pH of 7.42 with PCO2 of 20 and bicarbonate of 12.9.
Bicarbonate is 12.5, it is low. CO2 is?
20.
CO2 is washed out. O2?
O2 86.
86. Okay. That is normal. So in this case, you just imagine you are giving oxygen, like you told. What would happen if you continuously give high flow oxygen? You have only 2 liters. It is not going to make any damage to the patient. Suppose, unfortunately, you have started very high flow oxygen, thinking that this tachypnea is respiratory induced. What will happen to the patient?
Is a respiratory depression.
What happens to the patient if the carbon dioxide is completely washed out? What electrolyte or mineral change can occur?
Potassium.
Which mineral or electrolyte can come down drastically if you go to alkalosis? Potassium can have some effect. You are seeing now somebody is having tachypnea. What is a common finding you get? Bicarbonate, anyway, it is lost because of acidosis. I am talking about carbon dioxide washout, alkalosis, respiratory alkalosis. Calcium. You are seeing many patients who is having tetany, hyperventilation due to any reason ultimately produces hypocalcemia. This is not a loss of calcium, it's only shift of calcium. So that also we should think. So we should not allow the patient to go to respiratory alkalosis. Anyway, the acidosis is here. Already it is there. Okay.
And X-ray was kind of within normal limits, sir. X-ray was nearly normal. No, any infiltrates were noted. And ECG was also showing sinus tachycardia. Other than that, ECG was no significant T changes were noted. On further,
what is the lactate in this?
Lactate was 6.2, sir.
6.2.
And create was 3.52.
So what are the reasons for acidosis here?
Sir,
one is lactate. Second one is renal failure. Third one is loss of bicarbonate. Through where?
Through GI loss and
GI tract. So all these areas patient is having. This may be multiple mechanism which is producing an acidosis. Okay.
And we moved on with our further assessment of the patient. Coming to the secondary survey, he was a known case of type 2 diabetes, systemic hypertension, and right sinonasal carcinoma.
Okay.
With the history of medial maxillectomy and flat reconstruction.
So he's not on any anti-malignancy drugs.
And followed by he had a recurrence in malignancy, but he was advised for radiotherapy and chemo, but he started with Ayurvedic treatment.
Okay.
And he was on Ayurvedic treatment before coming to our hospital.
Okay.
We don't know the actual which all are the Ayurvedic medications he is taking, but he is telling that he was having multiple Ayurvedic medication including kashayas and and patient was on medication like Silacar for hypertension and metformin and telmisartan also.
Okay.
So the history is that
metformin can it produce lactic acidosis?
Metformin produces lactate.
Book says penformin produces lactic acidosis. But normal course, metformin will not produce lactic acidosis. Even if you take some more tablets also, it will not produce normal dose. But if the patient is already having liver disease or renal disease, and it can aggravate the lactic acidosis, normally it will not produce lactic acidosis. Okay. But when the patient is already having lactic acidosis, better to stop the drug.
And the history is like he's a 48-year-old male who came to ER with complaints of vomiting, multiple episodes of vomiting and loose stools since the past 2 days, associated with high-grade fever with chills and rigor. He was also complaining of generalized tiredness. He gives a history of intake of food from outside, like 3 days back, which was including juices and multiple other food. So there was no history of any chest pain, palpitation, syncope, or no history of any bilateral pedal edema was also noted. So upon further evaluation, we did routine blood investigation and also USG abdomen was also taken. In USG abdomen, it was showing borderline hepatomegaly with mild to moderate fatty liver infiltration. And
why you have done USG abdomen in this patient?
Patient was having a complete multiple episode of loose stools and creatinine was also elevated, along with it lactate was also elevated. So I want to rule out any chances of any chronic renal failure as he was taking Ayurvedic medications.
Normally Ayurvedic medications will not produce chronic renal failure, only if it contains lead. Some preparations may contain lead. That can produce sometimes if you take chronically that type of drugs which contain lead can produce sometimes renal failure. But we are doing an ultrasound here to know whether he is having pre-existing kidney disease or not. That is the main this one. How do you know the pre-existing kidney disease is present or not? Corticomedullary differentiation is preserved in a normal kidney. It is lost in chronic renal failure. So that is very important, and IVC diameter you can check. Okay.
IVC diameter was initially was collapsed, and we initially gave him fluid therapy with 30 ml per kg. Initial fluid boluses were given, but as such his BP was not picking up on the initial fluid management, and we started up upon him with the IV inotropic support. Was noradrenaline was initially started, and by that time we got the initial lab investigations. In initial lab investigations, his
so you want to give oral feeds for this patient, oral fluid. What is the common therapy for diarrhea?
Oral ORS can be given.
ORS is ideal. You want to give glucose water or simple ORS? What happens if you give glucose water to this patient?
Laxative.
It has got laxative effect, so it will aggravate. So always give a fluid with salt with sugar, or ORS is the best option. Okay.
So as patient was having a multiple episode of vomiting, we antiemetics were also given along with the.
What is the potassium level?
So initial potassium level, potassium was 4 and sodium was 136, sir. If on the first day of initial inflammatory markers, CRP came up to 88 with the total counts of 8.29 and HB was 12.
What IV fluid you want to give in this patient?
Crystalloids, normal saline.
Normal saline. Okay.
Then other lab parameters were within normal limit. We also sent for procal was also sent, sir. Procalcitonin was also sent, and it came out to be greater than 100 in our lab investigation.
What that indicates more than 100?
Procal is an indicator of how much is the bacterial load in our system. Usually, so in a bacterial infection, procal will be secreted from all the cells in the body, and
very high procalcitonin indicates what?
Large bacterial infection is.
It indicates sepsis.
Sepsis.
So otherwise, suppose it is 3, 4, 5, 6. It is a local infection. Here it is very high. That indicates the patient is developing a septicemia. Okay.
And as it is more greater than 100, high chance of gram-negative infection can be.
More than 100 indicates gram-negative
infection. So we started him on.
What are the organisms which affects the GI tract? Gram-negative organisms.
Vibrio, cholera,
E.
coli, Klebsiella, then protease, then typhoid, salmonella.
What is the difference between E. coli and salmonella and other things? E. coli is a group of organisms. They are different from salmonella, cholera and all. How do you differentiate?
E. coli mostly produces toxins, and whereas salmonella also produces toxin and.
E. coli mostly produces a dysentery. What is dysentery?
Dysentery, blood,
Blood, hemorrhagic. Okay.
Hemorrhagic.
It will mostly produces hemorrhagic stools. Okay. Whereas in other like cholera, it is rice water stool. Large amount of stool. That Salmonella paratyphi, it produces stools. The amount will not be that much high like cholera or this one. Okay.
And he started him on empirical antibiotics along with the IV fluids and noradrenaline support. And during the course of stay in a hospital, his symptoms like his BP was not picking up on initial first 2 days. Along with it, his inflammatory markers also began to increase. Sir. His CRP came up to 391 in the first next day of admission, and creatine values were also showing an increase in trend. The creatine from 3 in the first day came up to 6, then increased to 7 and reached up to 10. Along with this, his urea values also were also increasing 50, which changed up to 100 and then 120.
Urine output?
Urine output was decreasing, showing a decrease in trend. Initial day it was showing a urine output of like less than nearly 50 ml per hour. Then it began to decrease, like it reached up to anuria and less than 10 ml per hour. And his repeat VBG was also showing acidosis with the bicarb reaching nearly up to 10. Bicarbonate reaching nearly up to 10. As he was having a decreased urine output, and we initiated him on hemodialysis also, sir. And after the dialysis, his tachypnea also decreased. Along with it, his bicarbonate also was showing an increasing trend. But in the next day also, because of the same symptoms, his symptoms were persisting. He was having continuous loose stools.
Lung infiltration in X-ray?
On the next day, lung showed initial minimal infiltration was seen. First X-ray was showing.
Uremic lung?
Yes, sir, a little.
What is your uremic lung? What do you mean by that?
Fluid.
In renal failure, there are two important problems for lung. One is fluid overload. If you are completely anuric and fluid overload, patient can have pulmonary edema. That is normal thing we observe here. But some patients, even without volume overload, they develop a type of ARDS, uremic lung. Because of high uremia, toxemia, this patient develops ARDS type of feature. That may not disappear with fluid restriction. Only after dialysis, you remove the high urea or toxins from the body, it may get relieved. So uremic lung is not only pulmonary edema. Pulmonary edema occurs when there is a large volume in the body, that especially occurs in chronic renal failure. Acute renal failure like this, without even complete volume depletion, patient can develop ARDS like feature. So we have to be very careful. That patient should go for dialysis immediately.
He had multiple sessions of dialysis following the next days. He had continuous per day dialysis for next 3-4 days, sir. And with the help of the dialysis, he was able to maintain his tachypnea reduced, and also we were able to taper the noradrenaline. And on further evaluation, next day we got the blood culture became positive for Salmonella group. As such, we didn't get which type asset. We got the blood culture positive Salmonella.
Which culture is more likely in this type of patients? Which type of Salmonella is more likely?
Salmonella paratyphi.
Paratyphi. How do you clinically differentiate typhi and paratyphi? What is the differentiation?
More symptoms will be more pronounced.
Typhi is mainly fever. Paratyphi is mainly diarrhea. Then many patients will have relative bradycardia. That both conditions are. What is relative bradycardia?
The patient will have a temperature, but the high temperature, but the pulse rate
relative tachycardia means relative number of heart rate, that will not be there.
Will not be there.
So patient will have high degree fever, but for that fever, there is no rise in the pulse. It will be normal. Okay. So that pulse rate when in this patient may be because of that. He is having only 100 pulse rate. That may be because of that. But even then, when there is a hypotension, he should have tachycardia. That is also not there. So some other problem is there. Patient is having like bradycardia may be due to something else, including the renal failure. Renal failure also can produce high urea and bradycardia.
And other than that, as this salmonella group were positive, but there was no raw spots or. But on USG, it was showing borderline hepatomegaly. No splenomegaly as such were noted, sir. And on further days, we monitored the patient for any chance of any
What antibiotic you should start for salmonella?
salmonella, fluoroquinolones, azithromycin, macrolides can be started. Then, if not, patient is having high degree of infection, then you can start cephalosporins.
Quinolone, most of the time salmonella is resistant to quinolones. So normally without culture report we don't prefer to give quinolones. If suppose you are suspecting salmonella, better to go for ceftriaxone or piperacillin tazobactam. In this patient we should go for piperacillin tazobactam or ceftriaxone. But if you after getting a culture report, if they are sensitive to quinolones, you can switch to quinolones also. Otherwise, better to go for ceftriaxone, especially when the patient is having multi-organ dysfunction, sepsis like this. Okay, either ceftriaxone or piperacillin tazobactam.
On further days, his CRP began to come down, sir, and also his urine output also began to improve. And we
So which quinolone? Suppose you want to start, which quinolone you will select?
Ciprofloxacin,
Ciprofloxacin or not norfloxacin, ciprofloxacin and ofloxacin. Norfloxacin is a urinary quinolone. Okay.
And on next days, his urine output began to improve, sir. And we stopped with the dialysis, and we are also tapered and stopped the noradrenaline support also.
Okay.
His symptoms began to improve, and he was maintaining room air, and also
How long you have to continue the antibiotic in this patient?
and 2 weeks.
Normally 1 week is enough, but if there is a persistent presence of bacteria in the stools only, you have to continue for longer time. That is to prevent the carrier state. So 7 days is mostly enough. Okay, most of the patients require only 7 days.
Yes, sir.
What happened to the patient after?
Patient is stable, sir, and maintaining on room air without any supports. His urine output also is improving.
Okay. If the patient develops altered behavior, suppose this patient develops altered behavior, what will be your choice of treatment? The patient develops hendrick encephalopathy. That entity is called as hendrick encephalopathy. It is not seen nowadays because we start antibiotic immediately. So many patients will initially itself they'll improve. But suppose due to some reason patient is not taken antibiotic, patient come with hendrick encephalopathy. What do you do?
Antibiotics, ceftriaxone.
What is the next choice other than ceftriaxone? Steroids. Dexamethasone should be given in higher dose. Okay, so that is the only condition in hendrick fever we use dexamethasone. Suppose we use dexamethasone in a patient with only fever with abdominal pain, what complication can occur?
Inflammation,
Perforation can occur. So we should never use steroid in a patient with hendrick fever unless until he is having a hendrick encephalopathy. Okay. So what are the conditions which can produce tachycardia in hendrick fever? Normally we learned that bradycardia or relative bradycardia. It's not actually bradycardia. It is only relative bradycardia. Conditions which produces tachycardia in hendrick fever.
hendrick encephalopathy.
What is it to do with the brain, like heart rate? That is peritonitis. Hendrick fever, if the patient is having tachycardia, mostly this patient had developed peritonitis. Sometimes, rarely, myocarditis also can produce tachycardia. Okay, so in a patient who is having hendrick fever, if the patient is having tachycardia, always take an abdomen erect X-ray. Okay, any patient with hendrick fever, if the patient is complaining about abdominal pain, it is always better to take a erect abdomen. Erect abdomen, what you are looking for?
Perforation, signs like free fluid in air under diaphragm.
Hair under diaphragm. That is very important. So any patient who is complaining about abdominal pain and hendrick fever, immediately take an erect abdomen X-ray. Rule out air under diaphragm. So that is a must. Okay. It may not occur in all patients, but if you miss it, patient will become bad very fast. Okay. These are the basic things we have to check in enteric fever. Patient has improved, we can discharge the patient. We have to only follow up the patient because some patients will become permanent carriers. For many years they will be carriers. They'll be their stool may contain the bacteria that can spread. Especially which type of people we have to be very careful.
Chronic carriers greater than 12 months.
Which type of job, this is very important.
Cooking.
Chefs cooking and all, we have to counsel them properly. Okay, thank you.